Bismillahirrahmanirrahim. In our last lecture, we discussed Graves' disease. The causes of hyperthyroidism. The most common cause of hyperthyroidism is the Graves' disease. Hyperthyroidism may also be caused by a toxic multinodular goiter. It may also be caused by a toxic adenoma. So today we discuss the toxic multinodular goiter, and this condition is also known as the Plummer syndrome. By toxic multinodular goiter or Plummer disease, we mean that the thyroid gland becomes enlarged, and when the thyroid gland is enlarged, it is commonly called as a goiter, and this enlarged thyroid gland or goiter has multiple nodules, and these nodules produce excess thyroid hormones causing hyperthyroidism. Now, the most common cause of toxic multinodular goiter is the deficiency in the dietary iodine. This type of condition in our country most commonly occur in hilly areas where the soil and water is iodine deficient. But now the supply of iodinated salt has greatly overcome this disease. The condition may also be caused by eating certain goitrogenous substances. Various vegetables and fruits are said to cause goitrogenous enlargement of the thyroid gland. Very rarely, there may be some hereditary enzymatic defect. For example, the defect may be in the thyroid peroxidase enzyme or the enzymes that cause coupling of the monoiodotyrosine and diiodotyrosine, and in these conditions the thyroid hormone synthesis is decreased, and as we know that the thyroid hormones are controlled by a feedback through anterior pituitary and hypothalamus by the level of the circulating thyroid hormones. When the circulating level of the thyroid hormones is decreased, what happens that this will stimulate the anterior pituitary to secrete excess TSH or thyroid stimulating hormone or thyrotropin. Now this TSH will cause hypertrophy and hyperplasia in an attempt to increase the size of the gland to secrete the required thyroid hormones. Now what happens that the enlarged thyroid gland or goiter that occurs in response to increase in TSH from the anterior pituitary due to hypertrophy and hyperplasia of the thyroid follicular cells. Now this is an attempt by the body to increase the synthesis of thyroid hormones by making an enlargement in the size and function of the thyroid gland brought about by the TSH or thyrotropin secreted from the anterior pituitary. Now, why the enlarged thyroid gland or the goiter is nodular? This is because some parts of the thyroid gland they are more sensitive and more responsive to the effect of the thyroid stimulating hormone. So compared to the other parts, these sensitive or more responsive parts, they grow larger. And overall, in this exercise, there is an uneven growth pattern of the thyroid gland and forming nodules. The nodules may be in the form of a single nodule, or mostly it is in the form of multiple nodules called multinodular goiter. Now, if the enlarged thyroid gland or the goiter is successful in increasing the secretion of the thyroid hormones, the patient who was hypothyroid now becomes euthyroid and normal. As I mentioned that the iodine deficiency is the most common cause of multinodular goiter. Iodine deficiency may occur due to lack of iodine or deficient iodine in water and soil, and as I said, this particularly occur in the hilly areas where the water and soil is deficient in iodine. If more than 10% of the population is affected by the multinodular goiter, the condition is said to be endemic. While the sporadic type of multinodular goiter, by sporadic means rare and here and there. So in this condition, which occurs irregularly and rarely in a population, the underlying cause is either goitrogenous substances, fruits and vegetables, or it may be due to a hereditary enzymatic defect, like defect in thyroid peroxidase or defect in the enzymes that cause coupling of the uh, iodinated tyrosines to form thyroid hormones. Mostly, the disease is more common in female and particularly in the young age. So, what happens when the thyroid gland is enlarged and it forms a goiter in an attempt and response to increase TSH with the intention that it will cause increased secretion of the thyroid hormones to fulfill the body requirements. So this is a compensatory increase in the thyroid gland to increase thyroid hormone synthesis and secretion. Now, if this exercise and this enlargement of the goiter or multinodular goiter, if it succeeds to increase thyroid hormone secretion and to overcome the deficiency, the patient who was initially in the state of iodine deficiency and who was hypothyroid now becomes normal and now becomes euthyroid with normal reference ranges of the thyroid hormones in the circulation. In situations where even this enlarged multinodular goiter due to severe iodine deficiency fails to overcome the deficiency and to secrete the required amounts of thyroid hormones, that may be uh, uh, mostly congenital or some biosynthetic defect. So what will happen that even the thyroid gland is enlarged, it has formed a multinodular goiter, but still the iodine deficiency is so much severe that it fails to overcome the deficiency and the patient turns into goiterous hypothyroidism. There is a goiter, but the patient is having hypothyroidism because of the severe iodine deficiency. Now, the multinodular goiter may be inactive or it may be very active. Normally, as a response to thyrotropin or TSH, the thyroid gland is converted into a multinodular goiter in an attempt to increase the secretion of thyroid hormones. And if it secretes so much thyroid hormones that it fulfills the requirement of the body, so we say this is the non-toxic multinodular goiter. But unfortunately, what happens that in the recurrent cycles of hyperproliferation and recovery of the thyroid follicular cells, the risks of genetic mutations is increased. And the genetic mutations that occur during the proliferation of thyroid follicular cells, they make autonomous thyroid tissue. By autonomous, we mean that in non-toxic multinodular goiter, the hormone production and the growth of the thyroid follicular cells did respond to the TSH. It was controlled by the TSH. Because when the TSH induced non-toxic multinodular goiter causes an increased production of the thyroid hormones, and if the blood or circulation level of the thyroid hormone becomes under the defined ranges, and if we can say if it becomes normal, it will suppress the secretion of the thyroid stimulating hormone. And in this stage, in the decreased secretion and stimulation of the thyroid stimulating hormone, the thyroid gland will undergo a stage of involution or a stage of recovery. But if genetic mutation occurs in the thyroid follicular cells, what will happen that now the hormone production will become autonomous. It will not obey the response to the thyroid stimulating hormone from the anterior pituitary. And there is hormone production even if there is no TSH. And this type of genetic mutations particularly occur in the TSH receptors. Now, these TSH receptors become autonomous. They do not play their role in response to TSH, and independent of TSH, they continue to produce thyroid hormones. Automatically, this independent of TSH secretion or excess secretion of the thyroid hormones will result in a hypermetabolic state or hyperthyroidism. Now, as I said, that when the diffuse non-toxic multinodular goiter secretes so much thyroid hormones that it maintains the defined circulating or defined circulating level of the thyroid hormones, what will happen that the TSH secretion will decrease and the thyroid gland will go into a stage of involution or recovery. In this situation, the gland consists of the normal flattened cuboidal cells. But since the iodine deficiency, if it is permanent, what will happen that again when iodine deficiency occur, TSH will stimulate growth of the thyroid gland. It will induce hypertrophy, increase in cellular size, and hyperplasia, increase in the cell number of the thyroid follicular cells. And in this situation, during the active phase, the cuboidal cells become hyperplastic columnar epithelial cells. Again, when the thyroid hormone secretion is increased and if it fulfills the required amount, recovery will occur. And this cycle of recurrent and repeated episodes, if unfortunately if mutation occurs in follicular cells and if the thyroid hormone secreting follicular cells becomes independent of TSH, which particularly occurs in mutations of the TSH receptors, what will happen that there will be autonomous toxic hormone production, and these nodules will produce thyroid hormones independent of the regulation by thyroid stimulating hormone from the anterior pituitary. And in this condition, what happens that a non-toxic multinodular goiter is turned into a toxic multinodular goiter. The non-toxic multinodular goiter was secreting thyroid hormones only to fulfill the body requirements. And after that, the TSH stopped them to secrete further hormone. But when the non-toxic multinodular goiter becomes toxic multinodular goiter, the toxic multinodular goiter will continually secrete thyroid hormones independent of the TSH. This condition is known as the Plummer syndrome or Plummer disease. So, as I said that a multinodular goiter may be inactive or it may be toxic. It becomes toxic when genetic mutations, particularly in the TSH receptor mutations, turn the multinodular goiter to secrete thyroid hormones independent of the TSH control. So, and as is true about any endocrine gland, it will cause its clinical manifestations because of its increased mass or the mass effects, and due to increased production or decreased production or underproduction of the hormones. So, the toxic multinodular goiter will produce the mass effects as well as effects due to excess thyroid hormone secretions or hyperthyroidism. Comparatively, the inactive or non-toxic multinodular goiter will produce only mass effects because here the thyroid hormone secretion is under the control of TSH, it is not independent, and the hyperthyroidism doesn't occur. But the patient remains mostly in an euthyroid state or normal state. The mass effects of inactive multinodular goiter or toxic multinodular goiters may be in the form of cosmetic problems due to the presence of a large mass uh, in the neck that cosmetically uh, looks unattractive for the patients and also for the viewers. The enlarged thyroid goiter may compress the trachea and esophagus, and it may cause airway obstruction and difficulty in swallowing. Sometimes the enlarged thyroid gland or multinodular goiter will compress the blood vessels in the near vicinity. For example, it may compress the superior vena cava, causing the superior vena cava syndrome. The chance of malignancy in toxic multinodular goiters or inactive multinodular goiters is less than 5%. So, the toxic multinodular goiter or non-toxic multinodular goiters, the malignancy is a rare complication. Now, to diagnose toxic multinodular goiters, we do thyroid function tests. The first line test is TSH and free T4 and free T3. In the euthyroid state, the T4 and T3 will be normal and TSH will be normal. But in severe iodine deficiency state, what will happen that the thyroid hormone level will be increased and TSH will be decreased. In the active state, the initially the free T4 and free T3 are decreased and thyroid stimulating hormone is increased. We can also make an ultrasound study of the multinodular goiter to see that either the goiters have converted into cystic spaces which are empty or fluid filled. And radioactive iodine uptake test can identify those nodules that are working independent of the TSH and are known as the hot nodules. In thyroid scanning or CT scanning, we use some radioactive isotopes. We may use radioactive iodine or we may use the technetium, which is comparatively having less side effects than radioiodine, but which is an isotope and it is taken up by the thyroid tissue, and also it may also show if there is ectopic secretion of the thyroid hormones, for example in stroma ovari where the teratoma has thyroid tissue and that secretes thyroid hormones. When we give radioiodine orally or technetium through an injection, after the administration we use a gamma camera and we take pictures which will take pictures of the radioactive substances. So a hot nodule will take excess radioactive tracer and it will appear more prominent in the thyroid scan, while the cool nodules they take very less or no radioactive tracers and gives this like appearance. But here one thing that I want to mention, that the hot nodules which take much of the radioactive isotope and which are more functional Compared to these hot nodules, the cooled nodules are more prone to become malignant. And when we see a cooled nodule, we should think about the fine needle aspiration cytology, because cooled nodules are have more risk to become malignant. If the radioactive tracer uptake is uniform throughout the thyroid gland, so this uniform type of diffuse uptake, it is it will indicate the Graves' disease, in which there is uniform hyperfunctioning thyroid tissue. In toxic or non-toxic multinodular goiter, since there are active nodules with normal areas in between the nodules, so it will give and it will show us the typical nodular appearance. Adenoma, which may also become toxic adenoma, is mostly hyperfunctional, and it will take excess radioactive isotope and will appear uh, as just like a hot nodule. But usually it is single and located at one site and can be differentiated from other hot nodules. The technetium isotope may also show us ectopic thyroid tissue. For example, in stroma ovari, which contains the ectopic thyroid tissue and cause hyperthyroidism. Now, the treatment of hyperthyroidism in general and toxic multinodular goiters include the beta blockers, because excess thyroid hormones cause overactive catecholamines, which may cause tachycardia, increased respiratory rate, tremors, anxiety, restlessness. So, beta blockers may use to control the overactivity of the catecholamines. And we know that one of the functions of the thyroid hormone is that increases the sensitivity of the cardiovascular system and central nervous system to the effects of catecholamines, adrenaline and noradrenaline. As for hyperthyroidism, we may think of partial or total surgical removal of the thyroid gland. If total removal of the surgical thyroid gland, known as total thyroidectomy, is done, so in this situation the patient will turn hypothyroid, and for the rest of his life he will be using synthetic thyroid hormones like thyroxine. In radioactive iodine therapy, what we do, that we know that radiation will destroy the thyroid tissue, and the thyroid tissue easily and rapidly cause uptake of the iodine. If the iodine is made radioactive, this means that we are giving poison in the food to the thyroid gland, and this radioactive iodine will be taken up by the hyperfunctioning thyroid nodules, and here the radioactive iodine will emit radiations, and it will destroy the thyroid gland, particularly if it is the uptake is more in the hot nodules, so expectedly it will damage the heart nodules more than the rest of the thyroid gland. We can also use antithyroid drugs like thionamides, which block the thyroid hormone production. We know that before iodine can be used to make thyroid hormones and iodinating the amino acid tyrosine, it must first be oxidized from iodide ion to elemental iodine. And for this oxidation, the thyroid peroxidase enzyme is essential. So, certain antithyroid drugs, for example, thionamides, they block the oxidation of iodide into iodine and in this way inhibit the synthesis of the thyroid hormones. We also know that T3 is made by coupling of the amino iodotyrosine and dioiodotyrosine, and it contains three iodines bound to the amino acid tyrosine. We also know that the thyroxine or tetraiodothyronine is made by the coupling of the two diiodotyrosines. And the drug thionamide also inhibit this coupling and formation of T3 and T4. But this type of medical therapy and using antithyroid drugs, we will use the medical treatment only for those patients where surgery or radioactive iodine therapy is inappropriate because of some other contraindications where we can't do surgery or radioactive iodine therapy. So we will use then the drugs that block thyroid hormone synthesis, but this is not so much efficient as we can expect from surgery and radioactive iodine therapy. Thank you very much.